So, welcome everyone. We have an echo. I give it a try one time. So,
Maybe he just said that you may want to mute the computer.
and now? Okay. So sorry for that, but welcome to everyone. So we have our lecture series going on today, so on epidemiology and prevention. And I'm really very happy to have Professor Launoy, who is here today. So Guy is a professor in public health and epidemiology at the University in Caen. It's in Normandy, France. And he is also the director of an INSERM unit called Anticipe. And this is an interdisciplinary group working on prevention, but also treatment in cancerology. And there they have multiple disciplines where they work on prevention, but also social inequalities, environmental exposure. They do have a cancer registry, a general cancer registry, but also a registry specific on colorectal cancers. And they also conduct digestive cancers, and they also work on the treatments, specifically on ovary cancers. Additionally to that, he's a director of the Canceropole Nord-Ouest, and I'm sure I also forgot many other hats you are having, but I'm really happy to have you here today, and so I hope you all enjoy his lecture, and of course we do have time afterwards for your questions and discussions. So Guy, the floor is yours.
Thank you, Claudine. It's a pleasure, and thank you for this very kind presentation. Okay, so we will talk about social inequalities, and certainly the first question is when we talk about social inequalities in health, what do we exactly talk about? From an epidemiological point of view, does it work? Okay, thank you. Okay, so with this one. Okay. Thank you. So, from an epidemiological point of view, social inequalities in health are defined by the observation of a difference in health associated with the place of people in the community, and as usually we use very usual indicators for health incidence, mortality, lethality, exposition, and for the place in the community we could use individual indicators as occupation, level in the social hierarchy, level of education, income, place of residence, and so on. But as opposed to intrinsic determinants of health, such as genetic factors or biological factors, which have a direct action on illness, the way social status influence health is not a direct pathway, but goes through different mediators as behavior or environment, for example. In this model, you can note that intrinsic factors can intervene in the general model of social determinants by interaction with these proximal factors, which we have identified as mediators for the role of a social status. That's the first difference. And the second fundamental difference with intrinsic factors is that the unequal distribution of these social factors that impact on health is not a natural phenomenon, but is constructed by human beings. In other words, it's socially constructed, and the influence of social determinants of health depends on the way society is organized, and therefore is modifiable by collective decisions. That explains this this rainbow model, which is very different of the model we can think about biological or genetic factors. In other words, social determinants of health and then social inequalities in health can be modulated by choices in policies for the organization of care or prevention, but also about employment policies, urban planning, transport, and so on. For example, if diseases are linked to occupational exposures, they can be prevented by regulating the protection of workers exposed to that particular exposure. If pathologies are linked to motor vehicle traffic, they can be prevented by regulating this traffic, so by collective protection, etc., etc. It can also be said that sex-related health inequalities could be biological, but gender-related health inequalities are social and then avoidable by collective decisions. For some time, proximal factors and in particular behavioral factors such as tobacco, alcohol, diet, were presented as the main mechanisms of social inequalities in health in the discourse of hygienists or moralists, setting first and foremost the individual responsibility of deprived people and dismissing the responsibility from the political sphere. Today, a number of studies and reports highlights the role of environment in the sense of air, water, and soil quality, and above all, the importance of the most distal factors associated with the organization of preventive care, transport, etc., etc. Acting on the causes of causes, as designated by our friends in Quebec, could be the most efficient way to reduce social inequalities, not on proximal factors, as behavior or environment, but acting on health organization, social organization, and political context. That's a general model of social inequalities in health we can propose to go further in the knowledge of these inequalities. So, what do we know about social inequalities in general? Social determination of health is a very long story, and that has long been observed in many pathologies, whether chronic as cancer or cardiovascular diseases, but also acute diseases or even violent deaths, as it has been observed. For example, in the sinking of Titanic, in Hurricane Katrina in USA, and more recently in different countries during the COVID epidemic, where the mortality rates were systematically higher in lowest social classes. Whatever the pathology concerned, a number of observations are now universal, and some of them challenging conventional wisdom. First, social inequalities are not expressed as a divide between a population that has access to the healthcare system and a population that is particularly precarious or social outcast. Health statistics show that, in fact, social inequalities in health cut across the whole of society, expressing a continuous gradient from the most privileged to the most disadvantaged classes, passing through all the intermediate categories. And so, reducing inequalities cannot therefore be based solely on a policy of helping the social outcast, but we need to think about a policy that concerns the whole of society, using in particular the notion of proportionate universalism, in other words, giving according to the needs. Second thing, for several years now, numerous researchers have also been demonstrating the association between social living conditions in early childhood and the onset of pathologies in adulthood. In this context, the social stress experienced in early childhood must be evoked to explain the social determination of certain diseases in adulthood. And this, what we call the life course epidemiology, also contributes to more recent and very, very exciting and very challenging hypothesis that supports that accumulating several situations or several years of social distress can lead to pathology by recognizable pathways with biological markers of stress or inflammatory markers. That's a very, very challenging issue nowadays. In other words, we can now show that chronic social deprivation can get under the skin, as sociologists say. Anyway, the scale of the social determination of health and the associated moral, ethical, philosophical, economic, political stakes are such that most national and international health authorities, and in particular the European Commission, have made the reduction of social inequalities in health as a priority in their political agenda. And in this context, a very recent European report indicated 3 priorities for reducing social inequalities in health. The first 2 do not fall within the field of the remit of research, but the third, on the other hand, is of direct concern to researchers. In detail, this priority involved ensures that systematic observation systems for health equity and social determinants of health exist at local, national, but also international levels, and at the European level obtain more comparative data and make more systematic transnational comparisons. We thus need to create tools and methodology to provide such a systematic observation at a European level. Concerning cancer, which is taught today, concerning cancer, such an objective assumes the availability in Europe of data that are available, reliable, and precise. That's the case. We can now say that that's the case for cancer data, incidence, mortality, thanks to European networks of cancer registries, European network cancer registries, and GRAIL. But nowadays, that is not the case for social status and social environment that can be characterized in a very different way according to the country. And for several years, there is a wide consensus that this socioeconomic status is a multi-dimensional entity and cannot be summed up by a single marker. It depends on individual income, education, social-professional categories, social network, but moreover, as shown by the different models I have previously discussed, it depends also on contextual elements associated with the place of residence and access to goods, services, facilities, and so on. European countries do not share the same culture, the same educational system, the same social structures, the same healthcare system, or the same macroeconomic environment. So it is inconceivable that any single index used identically in every European country is available to account for social environment in a relevant way in every country in Europe. So we need to think more deeply and propose not a single index, but a concept, a method that can be define the social deprivation in the same way in every European country. And suspense. Doesn't work. I have trouble. Doesn't work anymore.
No.
Okay, thanks. Okay, thank you. And that is the purpose of Townsend when he proposed some years ago the common concept of the relative poverty. Whatever the country, individuals may be considered, whatever the country, as deprived when they lack the resources to get diet, type of living conditions, amenities, services, which are commonly obtained by the majority of people in the societies to which they belong, what we call fundamental needs. This conceptual definition of deprivation, of relative deprivation, is the basis for the construction methodology of the European Deprivation Index that I will present just now. Okay. Since the beginning of this century, thank you. This study, the EuroSIG project, collecting all European countries' data on structural indicators of a social cohesion, and this survey includes a European standardized questionnaire specifically designed to study deprivation, consisting of 9 questions common to every European country, and these questions are capable to evaluate fundamental needs. So, every national version of European Deprivation Index is built with the same 3 steps. The first steps, which is the most important, use only European data and provides a bimodal variable, poor or not poor, for the national sample. The second step consists in identifying in the Eurostat survey variables that are also available in the national census. And the third consists in selecting among this set of common variables via a logistic regression, those associated with the variable bimodal constructed in the first step. If we want to have some details on each of these steps, the first step consists in constructing an individual indicator of deprivation based on the identification of fundamental needs in EuroSIG data. And so, in accordance with Thompson's definition of relative deprivation, a fundamental need is defined as a good or a service that fewer than the half of households did not have because they could not afford them. This table presents the results of an analysis of responses to the 9 common questions in the Euro 6 survey in various European countries. And for example, taking a week's annual holiday is considered as a fundamental need in France or in Portugal, where less than 30% in France and more than 30% in Portugal cannot benefit of it. But it is not considered as a fundamental need in Poland or Lithuania. Second example, having a computer is considered as a fundamental need in every country where less than 12% of people cannot get it. Among these needs, we then selected those associated with both objective poverty and subjective poverty. And in Spain, for example, among the 9 questions, only 3 of these fundamental needs among these 9 were associated with both objective and subjective poverty. At the end of this step, relevant fundamental needs that define poverty were identified for every European country, and people lacking a minimal number, which could be 2 or 1, of these fundamental needs was defined as poor. For example, in France, all people lacking at least 2 fundamental needs among the 6 which were identified is defined as poor. Okay, and that's the end of the full step of construction. In the step 2, which will be shorter, we need to put together the Eurosig data and the data of the national census to identify available variables in both. And these variables could be very different in every European country. For example, in France, 10 variables were shared in I think it's 2007, this analysis. In UK, that was 13, in Portugal that was 8, etc., etc. And in the step 3, a multi-variable logistic regression were conducted with European data to establish among this set of common variables those which were significantly and independently associated with the individual deprivation status as defined in step 1. Okay. And for example, the analysis conducted in 2007 for France selected 10 variables that constitute the components of this French version of EDI, of European Deprivation Index. And the coefficients of the final regression model are used to weight census variables at ecological level, and we were thus able to propose a mapping of deprivation in France. And in this year, 2007, this analysis has been conducted in 6 European countries, making us able to propose a mapping of comparable deprivation between these six countries. So, different national versions of European Deprivation Index is now available, and I would like to show you for the end of this presentation the way that helped to better understand the social determination of cancer in France this last years. What is established in France since several years, as in numerous countries, is the association between social status and cancer mortality. Usually, higher rate of cancer mortality is observed in lowest social class of general population. This association can be due between social status and mortality can be due to two different pathways. Association between social status and incidence, or association between social status and prognosis of cancer. These two pathways can be combined. In France, these questions have been deeply investigated thanks to the geolocalization of all cases of cancer collected by cancer registries belonging to the French network of cancer registries, allowing us to assess the deprivation level of more than 500,000 of people in France in 20 different departments. Focusing on incidence first, we showed that several localizations were, as expected, associated with high deprivation, as many in the left of this slide, as expected with many digestive localizations, lung and bladder cancer. But on the right of this slide, surprisingly, certain localizations were more frequent in affluent people, as prostate, melanoma for males, and also ovary for female. That was the first observations we made on incidence, an association which could be expressed in very opposite direction. And now, focusing on survival, we showed that except for very few and rare cancers, whatever the localization, the prognoses were constantly worse for people with lowest social status, for females as well as for males. And the highest social gradient was observed for digestive cancers, pancreas, liver cancer. In a further step, incidence and survival data were combined in a single analysis to identify for each cancer site the respective contribution of each of these pathways, incidence and survival, in the difference in mortality rate. And we identify three different patterns of cancer. The first pattern comprises cancer sites with higher incidence and lethality among the deprived, and for which social inequalities in mortality were mainly due to social inequalities in incidence, which is marked in blue in this slide, and it mainly concerns tobacco-related cancers as head and neck cancer, lung, and digestive cancers, like esophageal and stomach and liver cancer. In this group, you can note that lung cancer is the most frequent. The second pattern includes cancer size where the contribution of the excess incidence and excess lethality were comparable, both for men and women. This concerns the bladder cancer in both sexes, the liver in males, and lip, mouth, and pharynx, and cervix in female. And the third pattern was certainly the most striking, where the social gradient of incidence and lethality works in opposite directions, reduced incidence and excess lethality in the deprived people. For these sites, what is particularly striking is that although these cancers are less frequent in terms of incidence among the poorest people, the social gradient in survival is such that it outweighs this difference and means that in the end, mortality is higher among the poorest people. And this very interesting pattern concerns very frequent cancer sites for which screening is performed in France, in other words, breast, colorectal, and prostate cancer. And this incidence rate of cancers belonging to this pattern 3 is such that from a public health point of view, we think that the two priorities for reducing social inequalities in France in cancer seems to be the reduction of certainly incident social inequalities, the incidence for tobacco-dependent cancer as well, but if the first priority could be the reduction in survival differences. And that's a reason we continue to be focused on the analysis of social inequalities in survival. When we focus on these survival differences, the first observation, whatever the localization, is that for these inequalities take the form of this remarkable social gradient, as I talked before, with survival rates remarkably degressive from the most advantaged people, the most affluent people, to the most deprived people. The second observation concerns the key stages in the construction of these social inequalities. Most of the retrospective analysis carried out using logistic regression clearly show that these inequalities can be built at any point of the history of a disease. However, when we try to quantify the relative part of all these moments through mediation analysis, for example, it appears constantly that for cancers such as breast and colorectal, the crucial moment in the construction of social inequalities is the screening phase. For these cancers, the lack of participation in screening among the most disadvantaged population, that difference explains most of the social gradient in survival and therefore of the social gradient in mortality. And so, we therefore consider the study and reduction of inequalities in participation in screening to be the number one public health priority for a policy we want to reduce social inequalities in health. In France, cancer screening is decided at a national level, but organized at a local level, regional level. As we did with cancer registries, we contacted a sample of local structures and realized the geolocalization of a representative sample of women who were invited to screen to breast cancer, what we call the sister study. Sorry. Okay. And as expected, we showed in this study that a very regular social gradient, again, in participation to breast cancer screening with more than 10 points of participation lost between the most affluent and the most deprived women. And since the screening in France is supported by a mammography that must be done in a radiology center, we also geolocalized French radiology centers to identify women remote far from this radiology center. And as we found a social gradient, we found also, as well, a geographic gradient. women living more than 20 minutes far from a radiology center, losing almost 10 points, again, of participation in comparison with women living close to a radiology center. And as expected, women remoted were more deprived than others. So, a large part of the social inequality in participation to breast screening is in France due to the distance from the radiology center. And we therefore proposed to the French authorities to test the interest of using a mobile radiology unit. Is a French program in a pilot study conducted in Normandy. And in fact, a mobile unit is a specifically equipped truck with onboard mammography and also ultrasound that travels to the remotest corners of Normandy. And this intervention is being carried out only in remote areas far from a radiology center in a clustered randomized trial in which only the communes with the areas in the intervention arm will be visited, pink colored in this slide, in order to eventually compare these results obtained in control towns which without mammobile offer, which is gray colored in this slide. This trial is ongoing in Normandy since 2 years, and it's an example of the use of a geographical index to identify the target population. And back to the general model of a social determinants of health, conceptually, the idea to change the way the healthcare system is organized by offering screening at the door to change the behavior of people who are far removed from the general system. This intervention is in respect with the principle of a proportional universality. This added screening offer is proposed only to women living from the radiology center. The last part of the presentation was focused on a French study, but other studies has been conducted in Europe with very similar results concerning incidence, survival, or screening. And we think that even some national policies are capable to curbing the rise in inequality in health. We think that health inequalities should be analyzed and tackled at a European level. And concerning cancer, the European Network of Cancer Registries is a very useful tool, and we think that we should also develop the European Deprivation Index for Europe in the world to be able to compare health policies. We think that's a very big challenge for coming years. Thank you for your attention.
Thank you very much, Guy, and congratulations for this great presentation. So the floor is open for questions, comments, remarks. We also have some people online, so don't hesitate just to raise your hand and also open the mic. Is there any question in the room or? Yes, Sophie?
Thank you very much for this talk. Just wondering if you have, probably you have, look at the net survival by social inequality, but by deprivation level, but also by stage and by age.
Yeah.
And do you find the same pattern in each stage and age groups?
No, it could be different, but what is important with the stage is that different stage between the different social crises is the main explanation for difference in survival. Because, you know, the first stage of cancer is the crucial moment of social inequality constructions. And because disadvantaged people do not go to screening, do not go to the healthcare center when they have symptoms, they go later. So the main difference between social classes is the difference in stage of cancer. So when we stratify the analysis on the stages, we continue to observe differences between social classes, because there is other differences due to the place of treatment, etc. That could explain difference even when you conduct analysis in a given stage. But concerning stage of cancer, the main message is that's the main explanation of difference in survival.
Yes.
No, I didn't.
That's the reason why, because it's one of the main factors impacting survival. It's good also to see what is explained by the social status or what is explained by the late diagnosis, because I guess that even in affluent people, some people are diagnosed with advanced cancer. And so if we see the same pattern for stage 4 cancer, for instance, it's another story than if we find the same thing in stage 1 cancer, for instance. So that's why I was asking. And for by age, because it could also impact the access to care. I imagine that for mammography, it's up to 74 or 75 in France. And at 70, we know that some people may get frailer, not really. It could be not easy for them to go access treatment and so on.
I do not remember exactly the differences going to age, cannot explain. But to be simple, the distribution of stage is the main mediator of social status influence on health. We still have differences in stage 4 and stage 1. That could be explained by the difference in place of treatment, the difference in compliance. But from a public health point of view, the main issue is the first step concerning whether diagnosis or screening.
I may disagree, but that's okay. No, because it was all ages combined and so on. So I think, I think it was so important to stratify, to give a full story. Because even we can miss some specific group by combining all people together. I'm cancer epidemiologist as well, and more focused on older adults, and that's why I have a specific focus.
We do have a question online. Someone raised his hand, so maybe you can just unmute yourself and ask the question. Maybe it's aligned to what we're discussing. Jason, the first words.
Thank you very much, Dr. Launoy, for a very, very interesting talk. I was interested in your differentiation of objective and subjective poverty. Perhaps you could say a little bit more about how these are measured differently and the relative value, the distinct value of an objective versus subjective measure of poverty to be employed in cancer research.
Okay, thanks for this question. That's in the construction of EDI. The objective was to select very relevant fundamental needs. And in the Townsend definition on fundamental needs, he wants to include the fact that the people could not offer these needs. And that's the reason we selected among these fundamental needs those which were associated with both objective and subjective poverty. And definition of objective and subjective poverty is given in the European Eurocic study. Objective poverty is considered whether an individual is considered as poor when he has a standard of living below 60% of the median standard of living among each country. That's a definition of a Eurocic study. And subjective poverty was defined by one question on ability to make ends meet, and people respond to this question. Okay? It's a good answer for you?
Yes, thank you. Thank you.
Thank you very much. We do have another hand raised. It's from Valérie Morin. Could you also unmute yourself and ask your question?
Yes, thanks, Claudine. Thank you, Professor Launoy. It's a really interesting talk. My question relates the existence of other indices in national countries. So, for example, in Luxembourg, Statec have developed a socioeconomic index, and it's at the commune level, so also a small area level. And in England, there is an index of multiple deprivation, which is similar at a small area level. So is the advantage of the European deprivation index really the use in cross-country comparability, that you may have these national indicators, but you really cannot compare them across countries?
The question is on the interest of European Deprivation Index, comparison to national index. That's your question?
Yeah, exactly. I mean, if we already have an index
okay.
at a national level, what would be the benefit of the European Deprivation Index?
Okay. The first interest of this index is the comparability of data between the European countries. That's the main interest. The other interest is that we try to fund the construction of our index to very strong hypotheses presented by sociologists. And I think that this issue of fundamental needs, the first advantage is to make a possible comparison between European countries, but the second is it's correspond to a very interesting definition of deprivation, which is a multi-composed deprivation, because it includes it includes profession, occupation, income, education, but it also includes contextual elements. I think the proposition of this index is a good response to the multidimensional aspect of deprivation we have to take into account when we speak about deprivation. That's the interest. Third is that we try to propose this index at a very small geographical level. In each country, we build it in order to avoid, the ecological bias. For example, in Luxembourg, your national index is defined at the commune level. Okay, but the commune of Luxembourg, of the city of Luxembourg, is a commune, and you can imagine the size of the ecological bias you do when you consider that every inhabitant of Luxembourg shares the same level of life. Okay, that's the third advantage, and then maybe another positive point is that in France we have another national deprivation index, which is called the French Deprivation Index, FDEP, and when we compare these two indexes, each time we usually found this social gradient using EDI, and not at each time when you use the other index. So we think that French national version of EDI is very adapted, is very relevant to health issue because of particularly this social gradient. It's not an index which try to identify people very precarious or people out of the society. It's an index which try to identify the very different level of deprivation through the whole society.
Thank you.
And in France, we have found also that it works in a different way in rural areas and in urban areas. That has been observed in France, and we have to focus on this aspect in other countries also.
And just a compliment, François Pétier from Statec, I'm responsible for population statistics and for the creation of the index, the economic index socioeconomic. And we know also to know the aim of the index, because, for example, for Luxembourg, the only aim of this index is to finance the different municipalities. So we need to create and to provide this index on an annual basis. So we need also to have variables that we can update every year. So we have some limitations. So compare different index between country or even in the same country, it's not so easy. And we know we need to know the context and to make the better, a good comparison.
Thank you.
Thank you for your question, Valérie. I don't see any other hands raised. Personally, I would have also a question. So you discovered now a bit Luxembourg. It's still quite small compared to France or other countries. But let's say if we would compare the Luxembourgish deprivation index with the other countries, we still have a quite international population compared to others. How do you see this factor in the comparability at the international scale?
Yeah, because one specificity in Luxembourg is people who come from other countries to work in Luxembourg.
Yes.
I think we have to think about the specificity of different countries, and we could add, if necessary, we could add to the French, Luxembourg version of European Deprivation Index, this type of specificity we have to think about. But you know that fundamental needs is defined among the society you belong to, and French people who come in Luxembourg to work, they have their life in France. So I think we could use for these people the French index because their address is in France, and I think the society we have to refer for these people is more France than Luxembourg. I think so. But we have to think about.
Even if we don't speak about cross borders, we need to think that in Luxembourg the population is completely different from Belgium and France, for example, because half of the population is foreigner. 55% is not born in Luxembourg, so they have a migration background. They're not. They arrive in Luxembourg at, I don't know, 25 or 30 years old. So we need to take this element into account.
Absolutely.
Multicultural.
But this index is at individual level.
No.
This is area level.
Yeah, it's an aggregated index. Yes, that's very important.
No, it was not clear, but okay.
Okay. In this step, in the construction of EDI, what is complex is that in its construction, first we construct an individual level using data of Eurocid survey, which is individual. But at the end, that the final aim of this index is to provide an aggregated level, and until this last step, it is an individual démarche process. And we found this beta coefficient, which are individual coefficient of the logistical regression, and these coefficients are used at aggregated level, and they weigh such variables at this level. Okay, it's the same coefficient, but at the end, it's a area level index.
Have you compared with other, because it's just a following question from Valerie. But for instance, in the UK, they're using this IMC, and differently, it's not, they are taking other dimensions that you are not taking there.
Okay.
And have you compared, because I saw in the map, they are very blue, so I guess that blue is good, and red it's bad.
It's very,
and it's very blue in the UK. I was a bit surprised.
We discussed this aspect with our UK collaborators, and they explained. I can't remember because it's a long time ago. But in England, you have Thomson index, and you have also the IMD index. It's very similar, because the way of construction of a British index are also based on the use of fundamental needs. Okay.
Maybe they are taking the other dimension.
Yes, they take at the end. Okay. Because they don't use the Eurostat data; they use national data. But the general model they refer to is the same. Is the Thomson proposition.
Okay, and if you are comparing this deprivation index with their national one,
we have done that. Yeah, we have done that, but I can't.
Is it that as blue as it is now? Because there are so many research, a lot of research on social inequality, cancer in the UK. If there are no, it doesn't show very. It's not a problem based on that map. So why spending so much money in the UK for something? You know, that's
but I think I remember that there was not surprised about that, because they said that poverty, deprivation was very concentrated in towns in England, and people living far from cities are well off. In France, it's very different. It's a mixed population. In England, it's very marked between towns and campaign and rural areas.
Okay.
Any other question?
And that's the first version of a national version of EDI. But the interest of this index is also that Eurostat is updated regularly, and this national version is also regularly updated in each country, not at the same rate in every country. But we can adapt this index to the evolution of Eurostat data. That is very interesting, because we integrate the difference of the relative role of income, education in the time, but we use the same concept, and because we use the same concept of relative deprivation and the same methodology, we think that our data will be comparable in time. The components of each, it's a challenge, the components of each national version of EDI will be different, but precisely that's the reason that the comparison in time will be relevant. So the value of income in the deprivation can vary during time.
Yeah,
so
I understand. I understand very well. It's just,
Okay.
I think it's a great discussion which can be pursued for long, but I don't see any other raised hand. I don't know if someone in the room still has a question. But personally, I thank you very much for the presentation and also for the work. But I really think it's absolutely great is also the end of the story. It's not only that there is a deprivation, a comparison, but you also implement some changes you see. And I think that this is also great afterwards on the long run to see the impact of your truck. So I hope this will be successful, and I hope also in other countries they can do action about the results you're having. So congratulations for that. And thank you very much for being here. Thank you for all of those online. So we will have sandwiches here, but I thank
Not
you
online.
all for the, no, not online. So the session is recorded. It will be put online in the next days. So please feel free to share it with your colleagues, and hope to see you in the next lecture next month. So thank you all and have a good day. Bye-bye.
Thanks very much.
Thank you.
Bye.
Bye.
Merci beaucoup.
Merci à vous.